It's 2 a.m., you're staring at an eye and hesitating. Do you wake up the ophthalmologist now, or can it wait till the morning? Most eye complaints are not emergencies, but miss one that is, that could cost someone their vision. Let's go through eye emergencies that cannot wait, day or night. First up, the one you don't want to miss. A 71-year-old man falls and hits his left eye on the stairs. The CT orbits show a deformed globe. What do you do now? An open globe is a full-thickness wound of the outer layers of the eye, specifically the cornea or sclera, due to trauma. This is an eye emergency with risk of permanent vision loss, infection, and even globe loss. That's loss of the eye itself. It requires urgent surgical repair, ideally within 24 hours from the time of injury, not the time of patient presentation. An open globe can range from being very obvious to being subtle, and the mechanism of the trauma and exam provide helpful clues. Key signs and symptoms: decreased visual acuity, pupil abnormality, having an irregular shape like a peaked pupil, although the pupil may look normal in an open globe, relative afferent pupillary defect in RAPD, globe deformity on exam or imaging, visible intraocular contents like uveal or vitreal prolapse, a foreign body sticking out of the eye, positive Seidel test, anterior chamber abnormality where it's shallow, flat, the iris is pressed against the cornea, or it's abnormally deep. Magnification helps, but if you don't have a slit lamp, you can use a pen light and compare the anterior chamber of the injured eye to the non-injured eye. Also, hyphema, vitreous hemorrhage, eyelid edema, ecchymosis, and a 360 or near 360 bolus subconjunctival hemorrhage. That's a clue that the eye sustained a lot of force, and it's an open globe until proven otherwise. So what do you do now? Examine both eyes, even if the trauma or issue appears to only involve one eye. And to avoid being redundant in this video, this applies anytime you're seeing an eye patient. After the eye exam, immediately place an eye shield to protect the eye from further damage, like a clear eye shield. And this is important. Do not patch or put any pressure on the eye. Don't even put gauze that's taped to the eye. You don't want any pressure on the eye that could expulse intraocular contents. To see how to put an eye shield on someone else, check out the link in the description below. All right, you're also going to want to make the patient NPO for possible surgery under general anesthesia. Open globes often go right to the OR. Get imaging. An open globe is a clinical diagnosis, but imaging can help to rule in or rule out an open globe, especially during those times when it's kind of in the gray area. And it's also important to rule out an intraocular or intraorbital foreign body. The preferred imaging for eye trauma is a CT orbits without contrast with thin cuts. And I definitely recommend adding to the order to make the cuts as thin as possible so radiology knows. Consider starting broad spectrum IV antibiotics, update tetanus if indicated, and control pain and nausea for patient comfort, as well as to avoid intraocular pressure spikes, which could lead to expulsion of intraocular contents, worsening the injury. And that's also why it's important to counsel the patient to avoid Valsalva maneuvers as best as possible. And for activity restrictions, bed rest with assisted bathroom privileges. We don't want the injury to get any worse. When to call ophthalmology. After your exam, if there's concern for an open globe, call immediately. Now, before calling, it's helpful to have a brief trauma history, which eye was involved, the visual acuity of both eyes if it was able to be obtained safely, and really anytime you call an ophthalmologist, even if it's for dry eye, corneal abrasion, anything at all, always have a visual acuity for both eyes. Also, the pupillary exam, anterior segment findings, imaging results if available, clinical pictures to review if they're available, those are really helpful. Tetanus and NPO status, and whether or not IV antibiotics were started. What not to do: do not manipulate or apply any pressure to the eye. And this is the time when you avoid the eye pressure check. No tonal pen. Next up, a 63-year-old woman presents with an acute, red, painful eye and blurry vision of the left eye, and it's getting worse. She had cataract surgery just 4 days ago, and her visual acuity is light perception, and there's a hypopyon in the anterior chamber. Could this actually be endophthalmitis? Endophthalmitis is a severe, vision-threatening inflammation inside the eye involving the aqueous and vitreous humors, often due to an infection. It's often seen after intraocular procedures like cataract surgery or intravitreal injections, but it can also result from trauma or systemic infections like sepsis. Key signs and symptoms: vision decline that's often significant like hand motion or light perception visual acuity, a vision change like new floaters, eye pain, but note that some cases may present with minimal or no pain, photophobia, a red eye, hypopyon, epiphora, corneal edema, eyelid edema, and erythema, and there may be mucopurulent discharge. Vitritis on dilated eye exam or ultrasound if the view to the fundus is obscured, and a blunted red reflex. What to do? Ask about a recent eye surgery or injection and when it was. Check the best corrected visual acuity. This helps determine management, whether the patient might have a bedside procedure or go to the OR. Do a side-out test, especially if a bleb is present, to assess for a leaking bleb, because that could be the source of the infection. If there is a bleb leak, treat it like an open globe. NPO, eye shield, no pressure on the eye, call Ophtho. As a side note, a bleb is a small blister-like elevation created during glaucoma surgery to help drain fluid from the eye and lower eye pressure. If there's limited or no view to the fundus, do a B-scan ultrasound looking for vitritis, but defer the ultrasound anytime there's concern for an open globe or a leaking bleb. And consider making the patient NPO, but confirm with the consulting ophthalmologist. When to call. If you suspect endophthalmitis, call ophthalmology immediately, day or night. This is a true eye emergency and often requires urgent treatment to preserve vision. Next up, a 32-year-old man presents to the ED after a workplace chemical injury to his eyes. He's in severe pain, his eyes are red, tearing, and he can barely keep them open. What's the very first thing to do? A chemical injury happens when an acid or alkali substance comes in contact with the ocular surface. It's a serious, potentially vision-threatening eye emergency, and early recognition and immediate treatment are critical to saving both the vision and the eye. Key signs and symptoms: an abnormal ocular pH. The normal ocular pH is around 7. Decreased visual acuity, eye pain, which can be severe, tearing, photophobia, the inability to open the eye due to discomfort or photophobia, conjunctival injection or redness. There can also be blanching due to limbal ischemia. When blanching is present, the eye can look deceivingly white, which is a bad sign that indicates vessel damage and is a poor prognosis. There can also be corneal haze, swelling, or epithelial defects, eyelid edema, an eyelid laceration, conjunctival symblepharon or scarring, retained foreign body or chemical matter. The very first thing to do is irrigate the eye like crazy before the exam, before consulting ophthalmology, before anything. And ideally, irrigation begins as soon as the patient arrives. You can use normal saline or balanced salt solution, BSS, with a Morgan lens if it's tolerated. How much irrigation? More than you think. If the initial pH is close to 7, you can start with at least 2 to 3 liters back to back. If it's further from normal, then do several liters back to back to back to back before rechecking the pH. And this is a key takeaway. It's better to over-irrigate than under-irrigate. Wait about 5 minutes after stopping irrigation before rechecking the pH. And this is to ensure that the pH doesn't change due to a retained foreign body that's hiding out somewhere. And always check the pH of both eyes, even if you're told the chemical only hit one eye. You never know. Once the pH is neutral, around 7, then do an eye exam, including checking visual acuity, fluorescein staining, looking for corneal or conjunctival epithelial defects, look for limbal ischemia, check the intraocular pressure, which can be elevated, especially in alkali injuries, but defer if there's any concern for an open globe, and carefully remove any visible foreign material. Everting the eyelids and carefully sweeping the fornices with a moist, sterile cotton tip applicator, aka a Q-tip, can help identify residual material. Now, if there is a foreign body penetrating the eye, do not remove it. That's now an open globe. NPO, eye shield, call Ophtho. When to call. Chemical injuries are true eye emergencies, so this is a time that you wake up the ophthalmologist if the patient came through in the middle of the night. But after copious irrigation and the pH has been confirmed to be 7. Of course, if you have any questions or there's something that is preventing the irrigation that you need to run through the ophthalmologist, then definitely call. The main point that I'm trying to make is that if I'm at bedside and the pH is still abnormal, I can't start my exam. The priority is irrigation, and it can take a while. Sometimes these cases need 5, 10, even 15 or more liters, and then once the pH has been neutralized to 7, then I can do my exam. Here's some helpful information to relay. The time of injury, type of chemical, whether it was an acid or alkali. Alkali substances are typically more dangerous because they penetrate deeper and can cause more damage. When irrigation started and how many liters were used, the pH before and after irrigation, whether or not there's any concern for an open globe. Pertinent exam findings, if the patient was wearing eye protection or contact lenses, and clinical pictures if they're available. That's always helpful. Chemical injuries are true eye emergencies. Start irrigation immediately, neutralize the pH to 7, examine the eyes, then call ophthalmology day or night. Time is tissue. Let's keep it moving. A 67-year-old woman on Eliquis was in a motor vehicle accident. CT shows a left retrobulbar hemorrhage with tenting of the posterior globe. On exam, she has a relative afferent pupillary defect, a proptotic eye, and the pressure is elevated at 62. This is the emergency where you don't wait for ophthalmology. Wait, what? Got a better idea. What if you learned how to teleport? Or you got a cape, even better. Turn into a puddle and slide, or glide. Slide and glide. You want me to turn into a puddle as my superpower? Wait a minute, what was that from? Okay, slide and glide. Still gonna take a minute. Orbital compartment syndrome is a rare vision-threatening emergency that occurs when the intraorbital pressure rises above the perfusion pressure of the ophthalmic artery. And this can lead to ischemia and permanent vision loss if it's not treated immediately. Key signs and symptoms: decreased vision, eye pain, elevated eye pressure, often greater than 40 millimeters of mercury. As a rule of thumb, anytime you get an elevated pressure reading, check it at least 3 times to confirm. Sometimes it can be falsely elevated, especially with a tonal pen or if you're accidentally putting pressure on the eye. Other signs and symptoms: a relative afferent pupillary defect, decreased color vision, motility deficit that can lead to double vision, proptosis, significant conjunctival injection or redness, chemosis, corneal edema or epithelial defects from exposure, resistance to retropulsion, and possible optic nerve edema. So what do? Orbital compartment syndrome is a clinical diagnosis. If there's high suspicion, don't wait for imaging or ophthalmology. Perform an emergent lateral canthotomy and cantholysis to decompress the orbit with the goal of saving vision. It's been reported that retinal ischemia beyond about 90 to 120 minutes can cause irreversible blindness. Time is vision. Doing this procedure emergently can be very stressful, and if you haven't done it before, just the idea of it alone can be daunting. I get it. If you want to learn more about it, let me know in the comment section below. When to call: if you suspect orbital compartment syndrome, do the lateral canthotomy cantholysis first, then call ophthalmology. You can also have someone contact the on-call ophthalmologist while someone else is doing the procedure. I still think you should get a cape. Wait, with a big eye on it, because you can see, like everything, right? A 62-year-old woman comes to your ED just after midnight with severe right eye pain that started a couple hours ago. Also redness, blurry vision, and her right eyebrow hurts. She's covering her right eye because the lights really bother her, and the moment you walk into the room, she leans over and vomits. An acute red eye with severe eye pain, blurry vision, brow ache, with vomiting, get that tonal pen ready. Normally, aqueous humor, the fluid inside the eye, is produced behind the iris, travels between the iris and lens, through the pupil, and exits through the drainage angle at the front of the eye. In acute primary angle closure glaucoma, the iris presses against the lens, creating a block at the pupil, hence pupillary block. This stops the fluid from moving forward. The trapped fluid builds up behind the iris, causing the iris to bow forward, closing off the drainage angle, leading to a sudden rise in intraocular pressure. The eye pressure is often greater than 40 millimeters of mercury and can even reach the 50s, 60s, or even higher. And if it's not properly normalized, it can lead to optic neuropathy and irreversible vision loss. And this can happen pretty quickly, and these patients tend to be very symptomatic, which is what brings them in the middle of the night. Key signs and symptoms: severe eye pain that's often sudden and unilateral, a red, steamy eye with diffuse conjunctival injection, ciliary flush and corneal haze from corneal edema, blurry vision, halos around lights, a mid-dilated non-reactive pupil, go ahead and highlight that, and some clues of elevated eye pressure, headache, brow ache, and nausea vomiting, especially if any of these symptoms are associated with an acute red eye. Also, photophobia, light sensitivity, and the eye can be weeping with excess tearing. There can also be eyelid edema and anterior chamber inflammation. There are key exam findings that will help differentiate pupillary block from another red eye condition, and I'll list them on the screen, but a few that I want to highlight. Number 1, acute pupillary block patients tend to be miserable. They're usually very symptomatic and nauseous from the high eye pressure. Another key is the shape of the iris, which is bowed forward from the trapped aqueous humor behind it, pushing the iris forward. And this leads to the anterior chamber being deep centrally but shallow peripherally. And the third key exam finding is a mid-dilated, non-reactive pupil, especially if it's unilateral. So that's going to lead to anisocoria. So what do? As routine, check the 5-eye vital signs. And one of the most important steps is checking the intraocular pressure, which is often going to be greater than 40 millimeters of mercury in acute angle closure cases. And I'm gonna sound like a broken record, but anytime the eye pressure check is elevated greater than 21, check it at least 3 times to get an average and to confirm that it's truly elevated, because it can change the urgency of the management. If I'm being told there's concern for acute pupillary block, but the pressure is 18 compared to 56, well, the pressure of 56 is a lot more concerning. 18 is within normal, so there's likely something else going on other than acute pupillary block. If you don't have a tonopen or your tonopen decided to go on vacation, what you can do instead is digital palpation. And this is where, using your pointer finger, have the patient close their eye and gently palpate the globe. Normally, the eye should feel soft and formed. You can even do it on yourself to get a baseline. But when the pressure is really high, it's going to feel more firm, kind of like palpating a rock. Another thing to do is to ask about glaucoma history and if the patient uses any eye drops. Sometimes patients have eye pressure spikes because they ran out of their glaucoma medications weeks ago. But unlike an acute angle closure, these patients won't have iris bowing or a mid-dilated pupil. What not to do? Avoid dilating the pupil, so no mydriatic agents. It could exacerbate the angle closure. When to call? Call immediately with the best corrected visual acuity and eye pressure checks, plural, of both eyes. Acute angle closure is an ocular emergency that can result in permanent vision loss within hours if untreated. Just as an aside, the management of acute pupillary block often involves glaucoma medication and a laser procedure called a laser peripheral iridotomy, or LPI, done by an ophthalmologist. This procedure creates a small hole in the iris, creating an opening so the trapped fluid can bypass the iris lens block, decreasing the eye pressure. A 75-year-old male is transferred to your ED with sudden, painless vision loss in the right eye. He has a history of hypertension, hyperlipidemia, and has been smoking since his 20s. He's on many medications, but he forgot his list at home. The eye stroke. A central retinal artery occlusion, or CRAO, occurs when the central retinal artery, which supplies the inner retina, gets blocked by an embolus, thrombus, inflammation of vasculitis, trauma, or vasospasm. The retina is very sensitive to oxygen deprivation, even briefly, which can result in severe vision loss. A CRAO is the ocular equivalent of a cerebral stroke, and emergent transfer to a stroke center is recommended. Key signs and symptoms: sudden, painless monocular vision loss, which is often significant like hand motion or light perception. Possible visual field defect or a relative afferent pupillary defect. And the eye often looks normal externally. The abnormality is inside the eye. The fundus may look normal early on, but classic findings include retinal whitening, box scarring of retinal vessels, and a cherry red spot. CRAO, cherry red spot, know that for your next board exam. What to do now? A CRAO causes devastating vision loss, but it's also a systemic warning sign because it's associated with a higher risk of a concurrent or subsequent cerebral stroke. Once the CRAO is confirmed, initiate a full cerebral stroke workup. A small percentage of CRAOs are caused by giant cell arteritis, or GCA, also called temporal arteritis. For patients 50 years old and older, it's generally recommended to get GCA labs, especially if an embolus is not seen on exam or the patient has GCA-like symptoms like headache, jaw claudication, or scalp tenderness. GCA is a rare cause of a cerebral stroke, not just a CRAO. If a patient is younger than 50 in a confirmed retinal artery occlusion, a hypercoagulable workup is recommended. Treatment specifics are outside the scope of this video, but if you work at an ED, check whether your institution has an eye stroke protocol. So when to call? Call ophthalmology as soon as possible. Now, there are many causes of acute painless monocular vision loss. Moment of silence for my voice because I had to record this so many times. And ophthalmology can help confirm the diagnosis. But don't delay stroke workup if there's high clinical suspicion of a cerebral vascular event. Moving on. If you're still with me, take a sip of water, stay hydrated, go ahead and click that subscribe button, and let's move on to our next case. A 73-year-old Caucasian woman presents with sudden, painless vision loss in the right eye and a headache that feels kind of different. She mentions a similar episode last week that resolved on its own, but not this time, and it's worsening. The misdiagnosis that can be hard to diagnose. Giant cell arteritis, GCA, also called temporal arteritis, is a granulomatous vasculitis that affects medium and large arteries, including the superficial temporal, vertebral, ophthalmic, and posterior ciliary arteries. Inflammation of the ocular arteries can lead to vessel occlusion and acute vision loss, often due to arteritic anterior ischemic optic neuropathy. And if it's untreated, it can progress to permanent blindness and can involve the other eye within days. This is both an ophthalmic and systemic emergency. And the age is very important. GCA generally affects people 50 or older, commonly in the 70s, and it's more common in women. Key signs and symptoms: sudden, painless monocular vision loss, often 2200 or worse, decreased color vision, relative afferent pupillary defect, visual field defects, and the patient may have had a recent episode of transient vision loss or double vision, like in our case. They could also have current double vision, and that may be the only symptom on presentation. New or atypical headache, jaw or tongue claudication, fever, fatigue, weight loss, and symptoms of polymyalgia rheumatica, tender or nodular temporal artery, possible motility deficit. And for the fundus findings, the key is a chalky, white, swollen optic nerve with possible disc hemorrhages. And there may also be cotton wall spots and retinal whitening. So you're seeing a patient, it's the middle of the night, and you suspect GCA. What do you do right now? As always, going to check the 5 eye vital signs, especially the best corrected visual acuity, because GCA has the potential of involving both eyes. So you want to see what the visual acuity is right now. Palpate the temporal arteries, order GCA labs, CBC with platelets, ESR, CRP, and if any are abnormal, trend them. Consider a stroke workup and consult neurology if clinically indicated. And if it's available, perform a temporal artery ultrasound looking for the halo sign. If there's strong suspicion for GCA, start corticosteroids immediately. For example, there's confirmed vision loss or current double vision that's believed to be due to GCA, start IV methylprednisone 1 gram a day for about 3 days. Then transition to high-dose oral prednisone. And generally, that's 1 milligram per kilogram per day. If there's no vision involvement but GCA is likely, start with oral prednisone, typically 1 milligram per kilogram per day. But keep in mind, steroids are not benign, and there are many other causes of monocular vision loss that's not GCA, including diabetic retinopathy. Also, initiate the workup and communicate to the patient the need for a temporal artery biopsy, but don't delay steroids to get it. The biopsy is ideally performed as soon as possible within 1 to 2 weeks of starting treatment and can be arranged inpatient or outpatient. When to call? Immediately. Ophthalmology can help to confirm the cause of vision loss, or at least to rule out other mimickers, like non-arteritic ischemic optic neuropathy, vitreous hemorrhage, or retinal detachment. And just as a side note, sometimes GCA is suspected, but the eye exam is completely normal. And that's where it can be pretty tough, and a multidisciplinary approach can be helpful. A 17-year-old male was riding a dirt bike, lost control, and crashed into a ditch. You're checking his eye movements, and the moment he tries to look up, one eye is still looking at you. He pauses and says, I think I'm going to be sick. An eye injury causing nausea? That's definitely a red flag. Orbital fractures are common in facial trauma. They're typically caused by a blunt force leading to a break in one or more of the bones that make up the bony eye socket. And this can create an opening for orbital contents like the inferior rectus muscle to herniate or become trapped, especially if the bone snaps back like a trap door. Muscle entrapment is not common, and it's less likely in larger blowout fractures. But when it does occur, it's serious and potentially life-threatening. Why is that? The entrapped muscle can become ischemic, which can lead to impaired muscle function and diplopia or double vision. Even more concerning, it can trigger the oculocardiac reflex, leading to nausea, vomiting, bradycardia, or in rare cases, cardiac arrest. That's why urgent surgical release is recommended, especially if there's any cardiac involvement. Key signs and symptoms: ocular cardiac reflex triggered by eye movement, restricted eye movement, especially in vertical gaze and floor fractures, diplopia, pain with eye movement, especially when looking away from the fracture site, anophthalmos or sunken eye, eyelid edema, periorbital ecchymosis, and there may be V2 hypoesthesia due to infraorbital nerve injury which runs along the orbital floor, and a wide-eyed blowout fracture. More on this later. And the visual acuity may be normal in an orbital fracture. In these injuries, the orbital bones often absorb the bulk of the force protecting the globe or the eye. It's better for the bone to break than for the eye to rupture. What to do? Monitor vitals closely and watch for signs of the oculocardiac reflex. Check visual acuity, pupils, looking for an RAPD, and pay extra close attention when doing the extraocular movements, looking for any restriction, and seeing if the patient has double vision while you're doing the test. Rule out a globe rupture before checking the intraocular pressure. Gently palpate the rim for orbital step-offs. Assess for V2 hypoesthesia. And order a CT orbit without contrast with thin cuts to identify the fracture and assess for muscle entrapment. And consider making the patient NPO, especially if there's concern for entrapment. When to call? An orbital fracture with muscle entrapment, call immediately. While not all orbital fractures are emergencies, entrapment makes it one. And watch out for the wide-eyed blowout fracture, especially in kids. These can look deceivingly benign, little or no bruising or swelling, and the eye can even look normal. but underneath, there may be significant muscle entrapment. The mechanism of injury, a careful motility exam, and ruling out the presence of the ocular cardiac reflex can help to avoid missing this cryptic wide-eyed blowout fracture. A 47-year-old woman with a family history of rheumatoid arthritis presents with worsening redness and severe pain in her left eye. The pain worsens with eye movement, and she mentioned she hasn't been eating much because of jaw pain. Could this be GCA? Pretty unlikely because she's under 50. So what's going on? Scleritis is a severe, painful, and potentially destructive inflammation of the sclera, the white outer covering of the eye. It's more common in women, and about 50% of cases are associated with a systemic disease like rheumatoid arthritis that might not be diagnosed yet. Complications include scleral thinning and perforation, corneal involvement like keratitis or thinning, secondary glaucoma, and in posterior scleritis, exudative retinal detachment or macular edema. Just a couple examples, all of which can threaten vision. Key signs and symptoms. Scleritis is known for its severe, deep, boring eye pain that can radiate to the forehead, brow, jaw, or sinuses. And the pain often wakes patients up from sleep and worsens with eye movement. And that's because the extraocular muscles are tugging on an inflamed sclera, which is also tender to palpation. There can be decreased vision, elevated eye pressure, tearing, photophobia, characteristic violaceous scleral hue, which is best seen in natural lighting. There's inflammation of scleral, episcleral, and conjunctival vessels. Scleral vessels are large and deep and cannot be moved with a Q-tip, whereas conjunctival vessels are thin and do move with a Q-tip. There may be scleral edema or thinning, which increases the perforation risk. Anterior scleritis is more common, and it can be sectoral, nodular, or diffuse. And scleritis can be recurrent. So what do you do? Ask about systemic autoimmune symptoms like joint pain, swelling, skin changes, or fatigue. Order labs. Assess the sclera in natural light for the classic violaceous hue. The phenylephrine eye drop test can help to differentiate scleritis from episcleritis. Scleral vessels do not blanch with phenylephrine. Conjunctival vessels do. But because phenylephrine is a dilating eye drop, it will dilate the pupil for hours, temporarily changing the pupil exam. So consider holding off on this test until reviewing the case with the on-call ophthalmologist. If there's concern for posterior scleritis, get a B-scan ultrasound or orbital imaging. And this is interesting. Scleritis can sometimes mimic orbital cellulitis, which can make diagnosing difficult and deciding when to start steroids. More on this later. Alright, keeping this moving. Manage pain and provide initial supportive care. And the first-line treatment for mild to moderate scleritis is oral NSAIDs. If it's not improving, or in cases of posterior or necrotizing scleritis, systemic steroids may be needed. It is recommended to hold off on steroids until ophthalmology can evaluate the patient, especially if there's concern for infectious scleritis, like after recent pterygium surgery. If you don't have local ophthalmology coverage, arrange an urgent referral. And consider outpatient rheumatology referral depending on the case, and especially if autoimmune disease is suspected. So, the question of the hour, when to call? The emergent consultation, meaning call now if any of the following are present: severe eye pain, decreased vision, scleral or corneal thinning, necrotizing scleritis, the most severe and destructive type, posterior scleritis, which may present with proptosis and posterior segment findings, and the urgent consultation can likely wait a few hours if the patient is stable, there are no vision changes, and there are no signs of necrotizing, infectious, or posterior disease. But like any eye issue, when in doubt, consult the on-call ophthalmologist as soon as possible. A 24-year-old woman comes in at the start of your shift with a red, painful right eye for the past 2 days. She's been stretching her daily contacts to save money, wearing each pair for 2 to 3 days straight, sometimes longer. But now she can barely open the eye because of the pain and light sensitivity. A corneal ulcer is an open sore on the clear, dome-shaped surface of the eye, the cornea. It's often caused by an infection, especially bacterial, but can also be non-infectious, known as sterile ulcers. Corneal ulcers can progress rapidly, which could lead to corneal thinning, perforation, vision loss, or even loss of the eye if untreated. Key signs and symptoms include the sudden onset of eye pain, foreign body sensation, photophobia, decreased vision, diffuse conjunctival injection. These eyes can be really red. The ulcer is commonly a focal white or yellowish corneal opacity that may be surrounded by corneal edema. There's often one, but there can be multiple on one cornea. There can also be corneal epithelial defects that stain with fluorescein, anterior chamber reaction, including cells, flare, fibrin, or a hypopyon. That's the layering of white blood cells inferiorly within the anterior chamber. Discharge could be clear, so excessive tearing, or it could be mucopurulent. And there could be pupil abnormalities that can lead to anisocoria, which is unequal pupil sizes, especially if the corneal ulcer is unilateral. The pupil could be sluggish or small due to the inflammation in the anterior chamber, or it could be dilated if the intraocular pressure is really high, like greater than 40. And that's due to iris sphincter ischemia. So either scenario can cause anisocoria in a corneal ulcer. Other possible findings include eyelid erythema and swelling, punctate keratitis, lag ophthalmos, or other exposure-related findings like in a facial nerve palsy where the eyelids may not close. So you just started your shift with a corneal ulcer. What to do now? Ask about recent eye surgery, trauma, or contact lens wear, including if they sleep in their contacts. These are all possible risk factors. If there's any history of trauma, look for a foreign body and update tetanus if indicated. And on exam, look for a whitish, faint yellowish spot on the cornea and infiltrate. Also, a hazy, swollen cornea, corneal thinning, or a hypopyon in the anterior chamber. Use the fluorescein stain to look for a corneal epithelial defect that's often greater in size than the infiltrate itself. And use a fluorescein stain to perform the Seidel test to check for aqueous humor leak. Corneal thinning can lead to perforation. And if there is suspicion of a perforation, treat it as an open globe. Clear eye shield, NPO, activity restrictions, call Ophtho immediately. Check for a contact lens. If there's one on the eye, carefully remove it and throw it out. It may be the source of the infection. Also look for a foreign body and remove it if you're comfortable, or notify ophthalmology. If possible, take pictures for the on-call ophthalmologist. And if the ulcer looks infectious, especially in the contact lens wear, consider starting a topical antibiotic. For example, a fluoroquinolone like a moxifloxacin eye drop every hour. This is particularly important if ophthalmology access is limited, or if the patient needs to travel to reach the on-call ophthalmologist. What not to do? Do not patch the eye. This can worsen an infection. And avoid topical steroids unless directed by ophthalmology for that specific case. So when to call? Call ophthalmology as soon as possible, yes, including at night. Depending on the severity, the patient may need to be seen immediately, or it may be reasonable to follow up in clinic within a few hours. For example, you might call an ophthalmologist at 3 in the morning with clinical pictures that they can review. Maybe you're seeing a small peripheral corneal ulcer without corneal thinning. And depending on the case, they might recommend starting a frequent antibiotic eye drop and following up in clinic that morning at 8 a.m. The key is to confirm the plan directly with the on-call ophthalmologist. All right, we're going to take a moment to pause. We're going to take a deep breath. I know it sounds low woo-woo, but many times we don't breathe enough. Deep breath on the count of 3. 1, 2, 3. All right, here we go. A 58-year-old man presents with new floaters in his right eye that looks like a swarm of gnats. He says he can see your face clearly, but the upper right corner of his vision seems fuzzier than usual. A retinal detachment is a vision-threatening condition where the retina separates from its support layers like wallpaper peeling off a wall. An macula on detachment, the macula responsible for central vision, is still attached, it's still on. And urgent repair is needed to try to prevent vision loss, often done within 24 hours. In a macula off detachment, the macula has detached and central vision is already affected. Repair is still important, but can often wait a few days depending on the case. Key signs and symptoms: sudden, painless, monocular vision change or loss. The sudden onset of new floaters, and this is different than the occasional annoying floater that people notice against a white wall. New flashes of light or photopsia. And this is key for a retinal detachment compared to a retinal tear or the age-related posterior vitreous detachment or PVD, both of which can also cause flashes and floaters. But in a retinal detachment, there's often a peripheral visual field change or loss, often described as a curtain, veil, or shadow that may be expanding. In a retinal detachment, the central vision may be preserved. It can still be pretty good, even 20/20, if the macula is still attached, like in a MAC-on RD. Decreased visual acuity suggests a macula off detachment. So the visual acuity is a helpful clue of the status of the macula. The eye generally looks normal externally unless there was trauma, and a relative afferent pupillary defect, RAPD, may be present in large retinal detachments. What to do? Ask about timing and progression of symptoms. Check the best corrected visual acuity of both eyes. If a retinal detachment is suspected, make the patient NPO. Perform a B-scan ultrasound looking for a retinal detachment, a retinal tear, which can be difficult to see on ultrasound. Also look for a posterior vitreous detachment, PVD, and vitreous opacities like a vitreous hemorrhage, which can present as a sudden burst of floaters. And if available, get fundus photography. It's helpful, but it's not required for a consultation. All right, let's bring this home. When to call. But real quick, if anybody knows where this comes from, let me know in the comment section. Call me, beat me if you want to reach me. I'm not gonna sing it. All right, let's keep going. A macula retinal detachment is an eye emergency. If there's concern for a retinal detachment in general, MAC on or MAC off, I do recommend contacting the on-call ophthalmologist day or night. They can help determine the next steps and the urgency of repair. Retinal detachments are repaired by retina specialists, and the on-call ophthalmologist may not be a retina specialist. So depending on the case, the patient may need to be transferred to a facility with on-call retina coverage. Next up, a 21-year-old female boxer presents to your ED at 4 in the morning with worsening right eye pain, headache, and significant vision loss. You can't see the pupil at all. She mentions that she had an intense sparring session last night and got punched in her eye, but proudly lets you know that she won the fight and is still the champ. A hyphema is blood in the anterior chamber, the space between the cornea and iris, commonly due to blunt trauma like a sports injury, fall, or assault. Red blood cells and inflammatory cells collect in the anterior chamber. This can blur vision and clog the eye's drainage system, raising the intraocular pressure. And the risk is even higher if the chamber is completely filled with blood, known as an apohyphema, and in patients with sickle cell trait or disease. The red blood cells can sickle in the anterior chamber, making them more rigid and harder to filter through the drain, leading to high eye pressure spikes, risking optic nerve damage. Complications in any traumatic hyphema include secondary glaucoma, corneal blood staining, and permanent vision loss. Key signs and symptoms include eye pain, photophobia, tearing, blurred vision or decreased visual acuity, conjunctival injection. There may also be a subconjunctival hemorrhage depending on the trauma. And in a hyphema, the key is seeing blood in the anterior chamber. So you may see visible blood that's layering in the anterior chamber, often covering a part of the iris. But small hyphemas may be subtle and require slit lamp magnification to see the tiny floating red blood cells. The eye pressure may be elevated, and there may be a pupil abnormality. It could be sluggish or small due to inflammation in the anterior chamber. It could also be irregular or dilated due to traumatic iris muscle damage. And there may also be corneal edema. What to do now? In any eye trauma, the first thing to do is to rule out an open globe. Check the 5 eye vital signs, especially the eye pressure, but only after an open globe has been ruled out. Other things to do: examine the anterior chamber, ask about sickle cell status and glaucoma history, and while awaiting ophthalmology, keep the patient NPO just in case surgery is needed. In traumatic hyphemas, the anterior chamber is like a snow globe of cells, and we want the cells to start to settle inferiorly. So elevate the head to about 30 to 45 degrees, unless contraindicated. Limit activity, bed rest with bathroom privileges. We don't want any rebleeds. Place a clear eye shield, no patching. Avoid non-prescription blood thinners like NSAIDs and aspirin, and counsel the patient to avoid eye rubbing and Valsalva maneuvers. If the fundus view is blocked and the globe is intact, consider getting a B-scan ultrasound to check for a retinal detachment or vitreous hemorrhage. When to call? Consult ophthalmology for all hyphemas, day or night. Management is often conservative, but getting an ophthalmologist plugged in as soon as possible can help to prevent vision-threatening complications. Hyphemas are urgent. They're not always an emergency, but call immediately if the intraocular pressure is elevated, especially in the 30s or higher. Use the rule of 3 to confirm. The patient has sickle cell trait or disease. There's an 8-ball hyphema. Also, a patient may occasionally need to be admitted for close monitoring, like in a severe hyphema in a monocular patient, or if there's mentation or follow-up concerns. We've covered several high-stakes eye emergencies, situations where the need to call ophthalmology is now clear. But what about when it's in the gray area? The cases where you pause and start debating, should I call ophtho? 2 critical red flags that should always raise concern. First, significant vision loss, especially with a relative afferent pupillary defect or RAPD, optic nerve swelling, proptosis, motility deficit, new upper eyelid ptosis, or severe eye pain. But is the vision loss actually concerning or a super easy fix? What I want to know when I receive a call is, what is their best corrected visual acuity? You're seeing this patient Saturday afternoon and you're told he can't see anything on the eye chart. Told you need a cape. Is that my towel? Anyways, you recheck the visual acuity with the pinhole, which helps to estimate how much the vision can improve with correction, so glasses or contact lenses. And like magic, his vision significantly improves and his best corrected visual acuity is 20/25 in the right eye, 20/20 in the left eye. And then you notice his glasses sticking out of his shirt pocket. I was looking for those. So getting the best corrected visual acuity is going to help guide you. Is the vision at or close to the patient's baseline, or has it significantly decreased? If the latter, call day or night. If you want to learn more about how to check a patient's vision, I'll leave a link to this video down below. It's doing better than I thought, so thank you if you've already watched it. If you haven't, after this video, check out that video. The second red flag is significantly elevated intraocular pressure, or IOP. Specifically, a confirmed eye pressure of 30 to 40 or higher, but context matters. An acute rise in eye pressure often causes symptoms like eye pain, blurry vision, a headache, nausea, vomiting. So if the eye looks normal and the patient is just chilling there, no symptoms, the eye pressure reading might be wrong. Few tips for checking the intraocular pressure. Use a numbing eye drop like proparacaine or tetracaine so the patient doesn't reflexively squeeze the eye. That could falsely elevate the pressure. Remind the patient to breathe normally. Holding your breath can elevate the pressure. And avoid any pressure on the eye. Even resting your hand on the eyelid can falsely elevate the pressure. The bottom line is, if a patient comes in with confirmed significant vision loss or significantly elevated eye pressure, don't wait, call ophthalmology as soon as possible. These two exam findings can signal a possible vision-threatening condition. We've covered a lot, and your ophtho knowledge is booming. But now, let's really lock in. This is your high-yield recap for when you're the first to see an eye patient at 2 a.m. on Christmas Day, and apparently every eye clinic is closed. And don't worry about taking notes. Just relax, let the information sink in. If you want a copy of the downloadable notes, click the link in the description. In any eye trauma, rule out an open globe first, and do this before checking the eye pressure or doing an ultrasound. Open globe, no pressure on the eye. If there's 360 degrees of bullous subconjunctival hemorrhage in an eye trauma, that's an open globe until proven otherwise. A hypopion and an acute red eye after recent eye injection or surgery, rule out endophthalmitis. Anytime you're seeing an eye patient, always check the 5-eye vital signs. For vision, get the best corrected visual acuity. Have the patient wear their glasses during the test, or use a pinhole, link down below if you want to get one. Getting the best corrected visual acuity helps to distinguish true vision loss that might need to be seen now from refractive issues that can be managed outpatient. For eye pressure, if it's elevated, greater than 21, check it at least 3 times to get an average and to confirm that it's truly elevated. Sometimes the tonal pen misbehaves a little bit. An exception, no eye pressure checks if there's any concern for an open globe. In a chemical injury, the very first thing to do is to irrigate the eye like crazy until the ocular pH is neutral, about 7. It's better to over-irrigate than under-irrigate. A CREO is an eye stroke. That's a central retinal artery occlusion. Cherry red spot, retinal whitening, needs an emergent full stroke workup. And giant cell arteritis, or GCA, age matters. Keep it on your differential for any patient 50 years old or older with acute painless vision loss. Acute angle closure glaucoma, like pupillary block. Sudden onset of a steamy, red, painful eye. Elevated eye pressure that's often greater than 40. And remember these clues. An acute red eye with a new headache, brow ache, and or nausea vomiting, rule out elevated eye pressure. These patients tend to be miserable. Up to 50% of scleritis cases are associated with an underlying systemic disease like rheumatoid arthritis. Ask about joint pain or swelling, skin changes, fatigue, etc. And corneal ulcers do not patch the eye. It can worsen the infection. In a MAC-on retinal detachment, the macula is still on. It's still attached. Vision may still be good. Urgent repair is recommended to prevent vision loss, generally within 24 hours. In a MAC-off retinal detachment, or RD, the macula is off. It's detached. Visual acuity is usually poor and is generally repaired within days. This I'm going to highlight because it's really helpful. Taking clinical pictures is very helpful for when you contact the on-call ophthalmologist. Ophthalmology is very visual. Pun intended, let's get it. Avoid topical steroids unless directed by the ophthalmologist. They can worsen infections like bacterial corneal ulcers or infectious scleritis. Orbital fractures with muscle entrapment can trigger the oculocardiac reflex, even in the cryptic wide-eyed blowout fractures that externally don't look bad at all. All the while, there can be true entrapment, causing nausea, bradycardia, and rarely cardiac arrest. Hyphema. Checking the eye pressure is crucial, especially in sickle cell and apel hyphema patients, because the red blood cells can clog the drain, causing pressure spikes in secondary glaucoma. We've gone through clear-cut cases when, in my opinion, you should wake up an ophthalmologist and call day or night. A couple additions. Postseptal orbital cellulitis. Call immediately if any of the following are present. Vision change or loss, relative afferent pupillary defect, RAPD, proptosis, restricted eye movements, elevated intraocular pressure, especially greater than 30, orbital abscess on imaging, or rapid progression. Herpes zoster ophthalmicus or HCO. Call immediately if there's vision change or loss, an RAPD, new flashes or floaters that may indicate herpetic retinitis, a red eye, especially if there's corneal involvement, or a rash that involves the V1 dermatome, elevated intraocular pressure, especially greater than 30, or cranial nerve involvement. That's concerning for possible orbital or CNS spread. There are other scenarios that are not true ocular emergencies, but depending on the context, like severity, potential for vision loss, or urgency of follow-up, calling ophthalmology after hours may still be reasonable. Let's go through a few examples. Traumatic iritis with normal intraocular pressure and no globe rupture. That's not an emergency, but will need an eye exam and eye drops. If the patient is going to be admitted and there are no urgent eye concerns and the patient is not monocular, this could be a case where you may not need to call ophthalmology in the middle of the night. Instead, you call at 8 a.m. for an inpatient consult. But if the patient's going to be discharged from the ED after hours, a quick call can help confirm timing for follow-up and whether to start cycloplegic eye drops. Now, topical steroids are generally used in traumatic iritis, but it's recommended for topical steroids to be started after ophthalmology's exam to confirm the diagnosis and in case there's a contraindication to using steroids. Unlike an open globe, eyelid lacerations usually are not surgical emergencies, but they're often repaired within 24 to 48 hours, especially if the lid margin, canaliculus, tear duct, or levator is involved. As an oculoplastic surgeon, I've repaired many eyelid lacerations on call, from sports injuries to animal bites. And I generally like to know about them when they're identified. Early notification helps to coordinate imaging if it's needed, when to schedule the repair, and ruling out an open globe. An eyelid laceration with no open globe, well, that can be repaired soon. But an eyelid laceration with an open globe, now that's been escalated to an eye emergency. What are we looking for? Wait, I see it. A quick comment about flashes and floaters. It can be difficult to determine the urgency because floaters are common, especially as we age. As we who? Youthful, always. Wait. New flashes and floaters in an adult are often due to the age-related benign process, posterior vitreous detachment, or PVD. It can also be due to a migraine, but flashes and floaters can also be a clue of something else going on, like a retinal tear, detachment, vitreous hemorrhage, endophthalmitis, or even retinitis. A suggested workflow: ask about new flashes or floaters, emphasis on new. It's common for people to have the occasional floater that they've had for months or years. Ask about a curtain, veil, or shadow in the periphery that does not go away with blinking. That's concerning for a possible retinal detachment. Whether there was recent surgery or trauma, check the 5-eye vital signs. If available, do an ultrasound or get fundus imaging looking for retinal detachment and vitreous debris like vitritis and endophthalmitis or red blood cells in a vitreous hemorrhage. Take clinical pictures for ophthalmology to review and review the case with the on-call ophthalmologist who can help determine the urgency. And here's a bonus. Conditions that usually are not emergencies, aka times that you generally do not need to wake up an ophthalmologist in the middle of the night, but still does need outpatient follow-up. A subconjunctival hemorrhage. The exception is a bolus 360-degree or near 360 subconjunctival hemorrhage in a trauma. Rule out an open globe. A corneal abrasion without an infiltrate, especially if it's a slam dunk diagnosis, there's no other urgent concerns. Routine conjunctivitis, viral, allergic, that is non-neonatal, non-gonococcal, and there's no vision loss or corneal involvement. Now there can be some mild blurry vision. Maybe somebody tests 20/25, 20/30, and they're usually 20/20. You have them hold up the pinhole and boop, they're 20/25, 20/20, that improves, and there's nothing else going on. So it really depends on the clinical context and using your judgment. Also, a chalazion or stye, dry eye, and blepharitis. In a perfect world, everything would be clear cut. You have the symptoms, the signs, boom, you're gonna go right, you're gonna go left. You're gonna call or you're not gonna call. But there are going to be times where you're not sure whether to call. And sometimes the answer is, it depends. Not every case is textbook. So a rule of thumb, if there's enough clinical concern, you're not sure about the urgency, Err on the side of caution and call ophthalmology. Have photos ready and your exam findings, and absolutely get the best corrected visual acuity of both eyes, even if it's unilateral, before calling. The visual acuity is basically the password for an ophthalmology consult. All right.